And good evening, everyone. Welcome to my IVF-Life. Welcome to you, the European Fertility Society. We are back with yet another webinar, and today's topic is definitely an interesting one, an intriguing one, and I'm sure we will have a great session, a great and interesting session, no doubt. So, as you can see, we have a special guest for you tonight. This is Dr. Daniel Bodri. Hello, Dr. Bodri. It's great to have you back. It's been a while, so I'm glad that you are back, and you will be able to explain to us what PRP is, how it works, and of course when it should be indicated. So thank you so much for joining us tonight. How are you feeling? Hope all is great.
Good evening, Caroline. Thank you. It's really a pleasure to be invited again by my IVF Answers after a brief pause. So I'm really glad to talk about this topic, which is a new topic. So the application of what is commonly called PRP is quite recent. First publications started to appear only a few years ago in 2016. So I think it's definitely an interesting topic. And actually, most of the advanced clinics in Spain started to experiment with this kind of treatment.
Yep. So we are looking forward to what you have prepared. As always, let me remind everyone that we will start with Dr. Bodri's presentation. He's the Gynaecologist Fertility Specialist at IVF-Life, located in Alicante, Spain. So he's our expert tonight. I'm sure he will be happy to answer any of your questions, and those will be answered right after his presentation. Remember, all you need to do is just type those in the chat section, and I'm sure Dr. Bodri will be able to help you out with them. And before we start, as always, let me remind everyone and say huge thanks to Phenomatch that has been supporting European Fertility Society. If you don't know what Phenomatch is, I can only encourage you to have a look at this. This is a face matching tool, and we know that many clinics is already using this to find a perfect donor. So if you would like to have a visit, go to their website and see it. And also, as always, I want to remind that we are still looking for some volunteers. So if you feel that you could help us out, we are looking for people that are able to help us with transcriptions from our past webinars. We are still active, and we would love to just grow our platform more. So if this is something that you think you might be able to help us with, please get in touch with me. I'm Caroline, your host, and I'll be happy to share with you all that we actually are waiting for and what we need, actually. So please get in touch with me, Caroline at europeanfertilitysociety.com. This is where you can also find me, of course, as well. And yeah, I believe that will be it right now. More than ready to hear what Dr. Bodri has prepared for us. So Dr. Bodri, ready to start with your presentation?
Yes, thank you.
Brilliant. Let's go ahead. Here it is, of course.
Yeah, so as mentioned, this is really a new topic, and we will talk about the application of PRP products in the field of reproductive medicine. We will see during the talk that this is often called ovarian rejuvenation or PRP. Both of these terms will need a little bit of clarification later. So let's start. Allow me first a very brief self-introduction. I was trained in gynecology in Hungary and assisted reproduction in France and Spain. And I had quite extensive working experience working in different countries, Spain, Japan, and United Kingdom, in many renowned clinics. My clinical activity and also research interest is based on innovative ovarian stimulation protocols, including mild IVF, also egg donation, and also improving the procedure of embryo transfer and 3D ultrasound. So this is the outline of today's talk. First, we will talk a little bit about the ovaries, the ovarian reserve, the significance of diminished ovarian reserve, and significance of low responder patients in everyday clinical practice. Then we will touch on different PRP products and then some technical details. After this, I will explain the application of these PRP products for the ovaries to improve ovarian function. Following this, I will talk about additional techniques that we use routinely in our clinics of the IVF-Life group, because we believe that both diagnostics and treatment has to be like complete, and we evaluate every aspect so that after PRP treatment or any other treatment, the patient have the highest possibility of achieving success. And in the end, I will talk about some ongoing challenges with the application of PRP in the field of reproductive medicine. So the ovary is actually a remarkable organ, and it changes constantly during the whole life of a woman. I mean, from the embryo stage up until after the menopause. If you look at this diagram on the right, you can see the development of oocytes and the follicles that contain the oocytes from the microscopic stage until a mature follicle that measures approximately 2 centimeters. If you add up the days here, duration of each stage, then you arrive up until a very long duration of 300 days, almost a year, until oocyte develops from the microscopic stage until a mature follicle. So during this whole process, at each stage, you can see here the percentages of follicles that are lost during the development or become atretic. And actually, it's only the last maybe 50 days of this process where the follicles become sensitive to female hormones. And maybe during an ovarian stimulation, during the everyday practice of IVF, we can only influence maybe the last 2 weeks of the development of a follicle. So this underlines the whole importance of ovarian folliculogenesis and all the factors, including growth factors and other factors, non-hormonal factors that intervene in this process. So how can we measure the pool of available follicles? You can see on this graph that the number of these follicles peaks during the fetal life at approximately 7 million. But from that moment, the decline is constant. Actually, the accepted concept is that there's no renewal of follicles. Recently, it has been put into doubt. Maybe there are some ovarian stem cells that are able to produce new eggs and follicles, but probably under like normal conditions, this is not a significant number. So we have to remain in the same concept that the number of follicles is constantly declining during childhood, during puberty, but this also during the reproductive lifespan of a woman. And then this, from the late 30s, this decline becomes exponential up until the menopause, when practically no follicles remain, or maybe only a few thousand, approximately around the age of 50. So it is routine treatment, or I mean routine approach, diagnostic approach, to evaluate the number of or estimate the number of remaining ovarian pool. There are two methods of measuring it. One is the anti-Mullerian hormone, or AMH. You can see the average values here. Of course, one should take into account the unit of measurement, no? Because you have two types of units of measurement, and your value could change according to the unit of measurement that you are looking at. The higher the level, the more potential follicles a patient has. And there's quite a lot of variation between individuals of the same age. Another very useful tool, of course, is the ultrasound. And basically, we can see on a 2D ultrasound these black spots, the tiny follicles that are there in each menstrual cycle. At the beginning of the menstrual cycle, we can evaluate their number, and they correlate quite well with the maximum number of eggs maybe that we can obtain during a successful ovarian stimulation. So not only there's a problem of diminishing quantity or number of eggs with advancing female age, especially for patients over 40, but there's another problem of diminishing egg quality. So you can see here, the red line represents the chances of having a live birth through IVF, which is constantly declining from a success rate of 40 approximately, according to published literature. The yellow line represents the risk of having an early miscarriage during the first 3 months of pregnancy, which is increasing. And all this is related practically to this increase of chromosomically abnormal eggs in the ovarian tissue. So basically, the longer time period passes between the fetal life and when follicles are created until ovulation, the more likely that during the division of chromosomes there are errors and eggs end up with an extra chromosome or a missing chromosome. Even younger patients in their 20s or early 30s, they have a steady rate of 25-30% of chromosomically abnormal, non-viable eggs, but starts to increase exponentially from the late 30s. And in patients over 40, there's a double problem, diminished egg quantity and also diminished egg quality. So how can we investigate egg quality or quality of the resulting embryos? Actually, we are not looking at eggs, we are looking at embryos. So the only way to have any precise information on the genetic makeup of an embryo is to do pre-implantation genetic testing. And this graph shows simply that depending on female age, from the age of 35 onwards, less and less chromosomically normal viable embryos are expected according to female age. So for example, for patients of advanced female age that we have above 40, for example, maybe it's approximately 20 or 5% of embryos that we could expect to be chromosomically normal viable embryo. Of course, there are variations according to each patient. So I would definitely recommend to undergo an IVF cycle, but probably it has to be done with pre-implantation genetic testing above a certain age. So how often we see patients with diminished ovarian reserve and advanced maternal age in our everyday practice? I would say that it's very common, and more than half or even 2/3 of our patients nowadays fall in this category. Are there any treatments that we can use to increase the number of eggs or to improve maybe egg and embryo quality? Not so much. There are some hormonal interventions or additional medication that could be given, but their results are not so efficient. We might use them, but because there are no other options. So this has led to an interest in using other methods. And basically, this means that other methods like PRP products were also investigated in the field of reproductive medicine. So what is PRP or PRP products? Here I should bring up like a clarification. In our clinical practice, we use routinely PRGF, which is plasma, which is rich in growth factors. So it is also, of course, the platelet itself contains granules, and these granules contain many growth factors and other like cytokines and other active substances. So these play a role, of course, primarily in tissue regeneration if there's an injury. But of course, these PRP products, which we more precisely can call PRGF, or plasma-rich growth factors, have been used in different fields of medicine. No? Already since 1987, it was first used in heart surgery, and in other fields of medicine like orthopedics, sport medicine, traumatology, cosmetic surgery, ophthalmology, it is used routinely. It is a quite safe treatment because the product comes from the patient himself. So if it's handled properly, there's no risk of any immune reaction or infection, transmission of any infection or any other risk. So it has several decades of experience with its safe use. How do we obtain this product? First, we need to collect blood sample. So practically in our clinic, we could collect approximately like 36 milliliters of several tubes of blood, which seems to be a lot, but it's not so much. And then this blood is treated in a centrifuge, and the different parts of the blood are separated. So after centrifuging with a precise protocol, we have the lower part, which contains red blood cells. This is another cells. This is discarded. We have this upper yellowish part, which practically contains different concentrations of platelets. It's lower in the higher part, and then it becomes more dense. There's also this intermediate layer, which is called Buffy code, which contains a high amount of platelets and also leukocytes, white blood cells. So in our practice, we use this middle part. Of course, it is treated with a specific protocol. We use a closed system in our clinic, and the platelets need to be activated actually during the process. So there's a coagulum which is formed, and basically the resulting end product, which could be approximately 6 milliliters, it is like a yellowish plasma, a plasma rich in growth factors, many growth factors, much above the usual concentration that could be found in the blood. So this does not contain platelets or other white blood cells or other cells. So this is quite safe to use without the risk of any immune reaction or anything else. So let's talk a little bit about the application of this product in the field of reproductive medicine. There are two main applications. We will talk today about application in the ovaries. And who are there are up to 4 groups of different patients who could benefit from this treatment, according to publications that have appeared relatively recently. One group is those patients who where the ovarian function is already severely compromised. So basically, patients who are in premenopause, maybe between 40 to 50, or even on the verge of undergoing natural menopause. So here the periods become irregular, and the FSH hormone, which shows the stage of this menopause, is very high. Maybe there are some follicles, but the chances of obtaining any viable egg is very low. Another group of patients is also have like failing ovarian function, but it is premature. It happens before the age of 40, practically approximately 1% of female population. So this, in most cases, is idiopathic origin, meaning that the cause is unknown. Although there are, of course, some cases where it is there's a genetic cause, problem with the chromosomes, or an autoimmune cause. These cases, when there's another reason for the premature ovarian failure, are not good candidates to do this PRGF treatment. Maybe the largest groups of patients who try it in fertility clinics are those who have diminished ovarian reserve, low responders, or other types of poor prognosis, for example, few eggs or embryos of low quality. Also, it is controversial whether PRP can have an effect on egg or embryo quality. So these are the four main groups of patients who could benefit from this treatment, potentially. There are some contraindications, and I've seen a question about age limits. So if this ovarian insufficiency, the premature ovarian failure, is due to chromosomal problems or some genetic causes or autoimmune causes, this would mean a contraindication of the treatment, because PRGF treatment or the PRP treatment will not change the underlying cause, of course. Because we punctured the ovaries, that we will see in a moment, ovaries where it is difficult to do the puncture. So basically, in some cases, ovaries are stuck behind the uterus, or there's some history of previous pelvic surgery where there are scar tissue which hides the ovary, or if the patient is morbidly obese, although this is a relative contraindication. So in this case, it is more difficult simply technically to perform the injection of the ovaries. Of course, we should exclude any like suspicion of any cancerous process, whether it's gynecological or other. Severe endometriosis, like chocolate cysts or so, are also a contraindication to do this treatment. And regarding the age limit, well, younger age limit is probably self-explaining. The upper age limit, of course, is relative, but if it's fertility treatment, in Spain, usually we have an upper age limit of 50 years. If it's with the aim of improving or reversing the menopause, which is, of course, not the most classical indication, then there are some publications who've treated the patients above the age of 50. So what is the process itself? Once we have this product, which is like roughly 6 millimeters, has a 6 millimeter volume, this product. So it can be simply injected into the ovaries, the similar way as an egg collection is done during an IVF procedure. So basically, the patient would be sleeping. The patient is under sedation. There's an anesthesiologist who induces like this short sedation, 15 minutes maybe. And under ultrasound guidance, with the transvaginal ultrasound, we can puncture the ovaries with the same needle as is also used for egg collection. Here you can see practically what we can see. There's the ovary, which is like a 4 or 5 centimeter structure. The needle goes in here, and then when the product is injected, we see a small movement of the liquid. So on both sides, maybe up to 3 milliliters of liquid could be injected. So this procedure could be also done if the patient undergoes IVF treatment at the same time, well, immediately after the egg collection too. So first, the eggs are retrieved, And then the remaining ovary could be also injected with this product, with the aim that for a successive stimulation cycle, potentially we could have better results. So this could be done either on a stimulated ovary or maybe on an ovary like this, which is not stimulated. So this would be a video. We cannot see video on this platform, but you can appreciate here, no, that this is from the vagina where the needle goes in. The ovary is not very big, just 4 or 5 centimeter structure. And of course, we have to pay attention, only inject the ovary and avoid any structure like this big vessel here or the intestine, which could be seen here. So it's a quite simple, but still like a thorough procedure. So how a treatment protocol looks, I mean, in our clinic, for most of the patients fall into those patients who do fertility treatment. So not so much patients who want to revert their menopause, for example. No, so these patients usually in their early 40s. They undergo an ovarian stimulation, and we will talk later that our approach to IVF is the embryo banking approach. So it's not only one cycle of IVF, but we have to think about doing 2, 3, in some cases 4, as many cycles as necessary to accumulate a certain number of embryos. So in many cases, we do this initial injection of this PRGF product during the collection, during a stimulation. So basically, it's a 2-week stimulation with injections. We retrieve some eggs, and then immediately after retrieving the eggs, we infiltrate the ovaries with this product. Then we would do a follow-up period, which could vary between 1 to 6 months. And if signs are encouraging, then we can do a second stimulation too. Some authors also do a second PRP injection at this time. So, but because the effect could last several months, so we encourage after first PRP treatment to repeat stimulation cycles, and hopefully we can increase the egg yield with each cycle. So what the follow-up consists of? Well, we do, of course, ultrasound, 3D ultrasound, even Doppler vascularization is measured in the ovaries, which could be like an indirect sign of some effect. And of course, we can do hormone measurements because especially these 2 hormones, FSH and AMH, could change in a positive manner. AMH could increase and FSH could decrease, which is a sign that something is happening in the ovaries. So if we see some positive changes on a scan or like more of these tiny follicles appearing, or the hormone levels decreasing slightly, then we can start an ovarian stimulation. If not, then we can prolong the follow-up a little bit more. So what is the aim of all this treatment? Basically, ovarian reserve markers are only indirect measures of sort of positive outcome. What is interesting for us is to improve the number of eggs, because it has been described in numerous publications that even a few eggs more for a low responder patient could mean like a significant difference in embryo number, and we could actually find the embryo which is chromosomically normal. So it is worthwhile to insist with the treatments, to repeat stimulations. And if it's the PRP treatment, the number of eggs, then it's definitely a positive outcome. Those publications that where patients in premenopause or premature ovarian failure were treated, of course, these patients could be also submitted to ovarian stimulation and fertility treatment. But in these patients, it could be observed whether there's a return of the menstrual cycle, which would be like quite extraordinary, or if they are in premenopausal state, maybe the cycles become more regular. So this is another outcome measure. It is a little bit controverted whether there's not enough data yet to know whether this treatment could improve egg quality or embryo quality. Probably it's unlikely because maybe with this treatment some dormant follicles could be activated and we could have some more eggs, but why would this have an influence on the quality of the egg? No, so but it remains to be investigated. So I mean, if we obtain, let's imagine an embryo which is chromosomically normal, even if it's from a patient who's in her early 40s, with that, definitely we can have a good outcome, meaning up to 90% if we transfer such a genetically tested normal embryo. So basically, all the patients above 38, we do recommend to do preimplantation genetic testing. So some patients, of course, can also have a problem with their uterus, no? And that's another application of this PRGF treatment is to improve the lining. There are two types of patients, patients with a thin endometrial lining who do not develop enough lining. I mean, it becomes too thin due to different reasons, scar tissue mainly. Or also there are patients who have a good lining, but still they have many failed embryo transfers and the embryos simply don't implant. So we have two possibilities. One is a very simple treatment, intrauterine instillations, meaning with a simple plastic catheter, like doing an intrauterine insemination or embryo transfer. 1 milliliter of this PRGF yellowish liquid is introduced into the uterine cavity. The product diffuses and it can improve the lining. This procedure is repeated every 2 or 3 days before the actual embryo transfer. At our clinic, we have developed another method, which is quite innovative, using hysteroscopy, which is like a camera which is introduced inside the uterine cavity. And with a needle, we infiltrate this product just below the lining, so that this effect could be much more sustained. So this is hysteroscopic infiltration of the subendometrial part of the lining. Often we combine these two methods, and we had quite good results with these both. So let's talk a little bit about some additional techniques very quickly. I mean, this is more about our approach to fertility treatment. No? So as I have mentioned, we think about embryo banking if we think about IVF. So it's not only one cycle. A patient could do 2 or 4 or even more cycles if it's possible. Of course, it is a physical and psychological burden and also financial burden to do so many cycles. But we think that we have to pursue treatment aggressively, especially in patients over 40 or with low ovarian reserve. And our aim, depending on the patient age, is to accumulate 4 to 8 blastocysts, submit them to preimplantation genetic screening. Basically, we have a quite, good, very good actually, lab that can have very good results in terms of embryo development. So our routine approach is to cultivate the embryos until day 5, day 6 in time-lapse incubator. Here you can see a video. And then this so-called trophoectoderm biopsy is performed on an embryo that has reached this stage. And chromosomes are analyzed, and we can find those embryos that have a normal chromosomical complement, like here. And those embryos that have an extra chromosome or a missing chromosome are not viable. So once we find such an embryo, it becomes very important to pay attention to the part of the uterus, no? Because this embryo has to be implanted into a perfect uterus. We have all these series of tests. So basically, we use advanced ultrasound, 2D, 3D ultrasound. You can see some examples here. We can use the hysterosonography where a liquid is introduced, and we can diagnose very easily any anatomical problem of the uterus. Then we can also use the office hysteroscopy, which is very convenient procedure, which is cheap, takes only 3-4 minutes, and we can check the inside of the uterine cavity in the consultation room very easily. Also, we can take a biopsy of the lining. So a small sample of the lining is removed. And our genetic lab, actually we have a genetic and a molecular biology department that have developed these tests that I will show you now. So one is the endometrial receptivity assay test. It's our own test developed by our group. And we can pinpoint whether the patient's lining is suitable for implantation, whether the implantation window is shifted, which could happen in up to 30% of the cases, especially for patients who had previous failures or early pregnancy losses. So with the result of this test, we can adjust the implantation window for a next transfer. Also, we have developed this innovative test of immune cells in the endometrium itself. So this is called IMAP. And with this, we look at some 7 different immune cells and their proportions. So we can also adjust or investigate any causes of immunological pregnancy loss and such. And finally, a more recent test, microbiomap, with which we can evaluate the endometrial microbiota, so the microbes within the uterine cavity, which is not completely sterile as previously thought. And if we can find that most of the microbes are lactobacilli, in that case, it is a favorable environment to sustain an implantation and a pregnancy. So all these tests are done at our center. And if the uterus is investigated and everything is fine, and we have a genetically normal embryo, then the last step would be to do the perfect embryo transfer. So I'm particularly invested in this, and I had the opportunity to learn this method that we use routinely in our center in Alicante. Japanese method developed at the Cato Ladies Clinic, where practically we use the transvaginal ultrasound, so an internal ultrasound, to transfer the embryo. The usual approach in other clinics is to use an abdominal ultrasound from above, from the belly, with a full bladder of the patient, which of course is very uncomfortable. But with this method, which is an alternative, we can really pinpoint where to put the embryo after we have investigated the uterus with a 3D scan. So actually there are some evidence that choosing the place of the implantation, especially with a genetically tested embryo, could also increase the chances of success. So embryo transfer is the final crucial moment of this whole complex fertility treatment. So finally, I'm coming to the end. So a few words about ongoing challenges with this PRP treatment. So basically, in order to draw any conclusions or to do any studies, patient selection and inclusion criteria are very important. So at the moment, we're using it in many patients. There's quite a high demand for these treatment options, but if we want to know more about the outcomes, then definitely we have to use a stricter inclusion criteria so that also the conclusions could be more definitive. There are some differences between different PRP products. So we use a closed system, and we use PRGF. But depending on the type of the PRP product, also the effect could be different. No, So the protocols are also under development. For example, whether to use this ovarian PRGF during ovarian stimulation, during egg collection, or outside of stimulation, whether one or a repeat ovarian puncture is necessary. Even the puncture itself could be ultrasound guided, which of course is the easiest way. But there are some publications where it is done through laparoscopy or coldoscopy, which is a different type of endoscopic intervention, which potentially could be a more precise method of introducing this product. So as mentioned, at the moment, there are not too many publications, although there are more and more. And of course, there is a lack of randomized clinical trials, for example, which are quite difficult to perform. So at the moment, results are promising, but it is still an experimental process, which has to be taken into account. So a few words about our clinic. This is the headquarters of the IVF-Life clinics in Spain, in Alicante. We have like a state-of-the-art facilities with 3 operating theaters, 2 embryology labs, several consultation rooms, as mentioned, our own genetic and molecular biology department. So all of these previously mentioned tests and the pre-implantation genetic testing is also done in-house. And this is our medical team, multilingual, specialized in endoscopic surgery also, which is important for the PRP. So this is the IVF-Life group. We have 3 clinics in Spain, the headquarters in Alicante. We have another clinic in the capital in Madrid, and also one in the north of the country. And we have 2 clinics abroad, one in Baden-Baden, Germany, and one in Manchester in the UK. So as mentioned, one of our next topics will be about endometrial PRGF treatment. So for those patients who have potential uterine problems with the lining. Actually, we have started this before ovarian PRGF, so we have a little bit more precise experience with this, and the results are encouraging. So finally, I would like to call your attention on 2 online patient meetings that we'll have this month of November, and you can look at the details here. Thank you very much for your attention.
Thank you so much indeed, Dr. Bodri. This has been a thorough explanation indeed. So thanks a lot. It's been useful. I have no doubt here. And as you can see, I was sure that there will be a discussion, big discussion. As you can see, plenty of questions are right here. So let's get to them, okay? I will start from the very first question Sam has asked. There are a few questions in one, okay? So just let me show you the first part. I'm 38 and starting IVF despite a full protocol, then reverting to mini or mild IVF. It had the same outcome. The follicles were empty, only 1 egg retrieved. I am healthy, have no medical history of illness, am of healthy weight. And what would you advise for me? My progesterone is 28 nanograms, I believe, right? Consistent with ovulation, and FSH is 7.6. Anything you can advise?
So so these are normal values, and the fact that 1 egg was retrieved once, it's sort of a positive thing. Also, the age is a positive factor at 38. So I would definitely recommend to try to do other stimulations. Well, actually, mild IVF or mini IVF, I had the opportunity to work in Japan, where they only do mini IVF, and the drawback of this approach, of course, that many of the collection or the embryo transfers don't arrive until the end, So it has a sort of low efficiency. Of course, the question: what other protocols could be tried? We could analyze it, of course, if you send us some information, but definitely I think you would be a good candidate to do this ovarian PRP, probably like with the idea of doing several stimulations, even if it's a few eggs, than potentially trying to create blastocysts potentially. Yes.
Thanks, Sam, for your question. Dr. Bodri, thank you for your advice here. Okay, and how about this? Is there any age limit for this treatment? You've mentioned this, but if you can.
I mean, yeah, we have this age limit of 50, like generally, like treating for fertility treatment in Spain, even across the clinics, it's quite consistent. So up until 50, probably you would be sort of treated, although it's true that with own eggs, after 45, the results are very low, no? So in some publications, they do patients undergo PRP treatment, and then in some cases there are spontaneous pregnancies, no? So probably it's not a stretch if somebody has like PRP over between the age of 45 to 50 and tries to do some simpler treatments or ovulation induction or so, if there's any positive response to the PRP treatment. So there could be at least a trial of the PRP, whether it improves some of these ovarian reserve markers and hormone results.
All right, thank you for your next question. Next question is actually here. Why are a lot of gynecologists reluctant about PRP, ovarian rejuvenation?
Well, it's a new thing, appeared a few years ago, depending on the country, of course, no? Because I mean, many of these publications, for example, come from Greece or some countries like Iran or South America or Turkey. So maybe less of them or practically none of them from European countries. There are some studies that are already registered on a website where these studies need to be like sort of registered. So there's some activity going on, but not all the clinics have the innovative spirit to launch it. Although more and more clinics in Spain are starting to do it. That's for sure.
All right, thank you for this question, Nate, as well. Okay, Karen has another interesting question. As the product comes from the patient, how does removing it and separating the blood from the platelet-rich plasma help?
Well, because it is sort of concentrated, no? So even if the blood has platelets, of course, and well, there are growth factors in the platelets, but these platelets are concentrated, they are activated. So actually, in the end, we would have like a plasma which is full of growth factors, and if it's introduced in the right place, I mean, in normal circumstances, you would not have such a high concentration, whether you use it in the knee joint or if you introduce it like to stimulate the growth of hair follicles. Of course, I don't have any experience with these treatments, but if you introduce it in the uterine cavity and the lining, which is changing all the time and is under the influence of some of these growth factors, if it's exposed to a higher concentration, probably it could potentially help.
All right, thank you. And Karen has a comment. That's helpful to understand about the location and concentration. Thank you so much indeed, Karen, for your question and your help with that, Dr. Bodri. Next question we have is from Jorge. Do you use PRGF injection in both low responders and diminished ovarian reserve and even advanced age patients?
Yes, basically, well, of course, because often they are sort of combined, no? So if you want to increase the egg yield, I mean, then we do it. Although it's also true that many of these patients have a poor prognosis, no? Meaning that maybe they have already done treatments with us, and then since this treatment option, the PRP, has become available, then so maybe these patients have failed cycles behind them, done at our center. So these are like not easy patients, and try to offer them like something new, no? So, but definitely, yeah, low responders, diminished ovarian reserve, practically the same, and advanced age patients are good candidates, no? Unless an advanced stage patient, in some cases we see with good ovarian reserve, in that case probably it's not necessary, but it's more the exception than the rule.
All right. Thank you. I hope that helps as well. And if we are actually on this topic, can you perhaps take a look what is exactly considered diminished ovarian reserve? Thank you for being specific. Number of egg stimulation.
Well, if there are these groups, Bologna criteria and Poseidon criteria. So basically, it is based on a AMH cutoff level, 1.2 nanogram per milliliter, for example. That if somebody has this low value, then this patient already qualifies as DOR, or diminished ovarian reserve patient. Also, if it's there's a previous history of ovarian stimulation, if there are 3 eggs or less, then it is definitely confirmed low ovarian response.
Okay, and while we are again on that, perhaps you can clarify, is there a difference between premature ovarian failure, diminished ovarian reserve, premature menopause?
Yes, there's premature ovarian failure or premature menopause is basically the same. Maybe it's more correct to call premature menopause as premature ovarian failure, like medically, and also these patients maybe don't really like to be called like menopausal, because some of them are really young. But definitely, from the medical point of view, their ovarian function is completely exhausted. They don't have maybe spontaneous cycles, or on the verge of cycles stopping. Their hormone levels are high. Diminished ovarian reserve, these patients can be younger patients or patients in their 40s. They could have completely normal menstrual cycles, or maybe slightly irregular ones, or shorter cycles. But they have the issue that potentially they cannot produce a high number of eggs, meaning 3 or less. So these are similar categories, but their ovarian function are still fine. But it is the number of eggs with an IVF treatment that could be impaired.
Thank you so much indeed for explaining this to us as well. Can you tell us about success rate, PRP procedure?
It's difficult to calculate because it depends on each patient group, no? So even very few publications give like a precise number. So it's still something that is under under investigation. So more cycles, more patients are needed to have some definitive answers.
All right, thank you. Can you have a look at this? It's not a question, but if you can have a look. Studies show endometrial PRP help in patients with severe endometriosis. Anything you can say on that?
Yes, I've mentioned as endometriosis could be maybe like a relative contraindication. Of course, when we see an ovary, and often the reason to have like a diminished ovarian reserve is endometriosis and the destruction of the ovarian tissue by the endometrioma. So if this product is carefully, injected into the remaining ovarian tissue, avoiding this chocolate cyst endometrioma, then it could be potentially used. So it is sort of a relative contraindication. Simply these sort of growth factors, nobody knows what happens if it's injected into an endometrioma. Probably a good idea to avoid it. But in the remaining ovarian tissue, maybe it could be still applied.
Understood. Thank you once again for yet another question. Can the ovarian PRGF improve egg quality in a patient with low ovarian reserve?
Yeah, it's the $1 million question. There's variation from cycle to cycle in egg quality, so it's difficult to tell if after PRP, for example, we have a a cycle from which we can obtain a genetically normal embryo, whether it's because of the PRP or not. So higher numbers are necessary to check this. We would be even happy if egg quantity could be improved and egg quality. It's difficult to know. Potentially, we're trying to activate some follicles and improve egg quantity.
All right, understood. For someone 44 years old, is it still worthwhile to increase egg numbers given the high number of poor quality eggs?
Yeah, well, I mean, you have seen different patients, you know, so in some cases, of course, at 44, maybe the proportion of chromosomically normal embryos is maybe not more than 5 or 10% on average. So one really has to analyze several embryos so that there's any mathematical chance to find a normal embryo. But if the patient still has a good reserve, maybe in that case she would not be candidate for PRP treatment. But yeah, I mean, we do have requests, and in some cases we do even for these patients. Yes, okay. 45 probably would be the upper age limit for these patients to do treatment.
Understood. Thank you so much indeed. What about fibroids? Can PRGF be done for such patients?
Well, probably I'm not aware application of PRP for fibroids. If you think that it sort of stimulates growth and thaw and like vascularization, because it has like vascularization factors too, then probably it's not a really good idea to inject fibroids. Yes. You might have an opposite effect. Yeah.
Okay. Next question. Is this treatment suitable for a patient with, I believe, poor ovarian reserve, perhaps, but that had thrombosis episode, genetic thrombophilia?
It is sort of in publications, and sometimes it comes up as a contraindication factor. I mean, after thorough evaluation, risk and benefits, probably it still could be used if the patient agrees. We would review each case. Case by case. Of course, if there's no genetic reason for this clotting disorder, then probably it still would be okay to use.
That makes sense, of course. Again, thanks so much. Karen has a question. So if I understand correctly, the position of where the product is placed in the uterus can lead to better success.
I think yeah, what I was talking about the embryo transfer, no? It's where the embryo is put inside the uterus. There might be like a maximal implantation point. When we do the endometrial PRP, then we do it also under ultrasound guidance. So it's a little bit different if we introduce 1 milliliter of product into the uterine cavity, then it sort of diffuses. It's not a big volume, but it sort of can have an overall effect on the lining potentially. What I was saying during the presentation, it's more about the precise embryo transfer procedure itself with this Japanese method. Okay,
thank you. Derek has a short question. Do you have INGS gray area?
Well, it is more about a question for our colleagues at the genetics department. They would answer it happily. So if you can transmit to us, of course, each lab has its different threshold values to evaluate, and the mosaicism and all these are related to that. So we can discuss it with our genetics department.
Of course, that makes sense. Thanks so much, indeed. And let me go to the next question. And what symptoms factors would lead you to suggest IMAP in 40+ age group?
The IMAP is this investigating the immune cells in a sample of an endometrial lining. We suggest it practically for most of our patients who especially those who undergo, for example, an embryo transfer with a genetically tested embryo, because we might have only one or two of those embryos. So before doing an implantation, we do recommend endometrial biopsy, which will investigate all these three tests in a row. Of course, if a patient has a previous early pregnancy loss, recurrent implantation failure, then we would specifically recommend the IMAP test, also the endometrial receptivity test. But in many of our patients, we do this test for with different indications.
Right. Thanks so much. Karen has one more question. Sorry, I missed this, I think. Would you suggest taking AGH alongside going for PRP?
HCG or HCG hormone to improve implantation. There are some publications that use it. We would not mix it with PRP probably, because then we would not know the which one provides an effect. No, so we use it in those patients with IMAP test. In some patients we can see specific. Growth hormone. Yeah. Yes, sorry. Anyway, so in some patients we use the HCG if the EMAP shows that they have a specific immune disbalance. With growth hormones, we use it a lot of often during ovarian stimulation, and I'm aware of recent publications that even used it for endometrium. This is sort of a new thing. So, actually, PRP also, by definition, contains a lot of growth factors, no? So there could be a relation between the two, yeah.
Understood. Thanks a lot. And there's thank you from Karen as well. And we will go to the previous patient in regards to the fibroids. This was the question. Sorry, just give me a second. I lost it for a minute, but here it is. Regarding the fibroids, so posterior intramural, posterior subserosal, one is 6 centimeters. And the question is also, how to improve ovarian reserve if someone has fibroids?
Well, the two probably are not necessarily related, no? So of course, patients with advancing age, because the fibroids are constantly growing during reproductive lifetime of the patient. So also the fibroids would get bigger. I'm not aware of any relation between specifically low ovarian reserve and fibroids. Of course, sometimes egg collection is more difficult with fibroids, so that's also could be a reason why. Simply the ovaries are more difficult to access, but we try to manage it. So if there's an indication to use PRP to improve the ovarian reserve, it could be done, of course, in patients with fibroids, yes.
All right, thank you for the clarification as well. Next question, how long after PRP can I go ahead with IVF if I have low AMH level?
The minimum waiting time would be probably 1 month. We would do a follow-up, but because our approach is to do this embryo banking approach, so do 2, 3, 4 cycles. So maybe the effect will kick in maybe after 1 or 2 months or 3 months. So we would measure, of course, FSH and AMH consistently, and if there's an increase, we can go ahead with stimulation. But if the patient has an advanced age, then probably if an egg collection was already successful, then it's useful to repeat another stimulation and trying to accumulate as many embryos as possible.
Understood. And if I may ask, so how about PRP? Can it be repeated? Have you been able to?
Yes, there are some publications who do it during 2 successive ovarian stimulations, and they sort of show good results. It's a little bit maybe more complicated logistically, but not impossible. Yes.
Okay. Thank you as well for answering this question. Okay, let's have a look. Thanks for explaining again the Japanese transfer method. Where is ultrasound performed?
The ultrasound is the transvaginal ultrasound that one would have during ovarian stimulation. So in contrast with the abdominal ultrasound from above, from the belly, which is the method that is used by most clinics, and the patient has to have a full bladder, which sometimes is quite uncomfortable. This method uses this transvaginal ultrasound, which is better because it has a higher resolution. No? But not all the doctors are familiar with this method, except maybe in Japan and in our clinic in Spain.
Understood. Thank you for yet another question. Okay, let's have a look. What increase in follicles can typically be expected after PRP?
It's not like a huge increase, but maybe a few follicles only. No? So it's also difficult to tell whether it's like normal variation or it is related to PRP.
Mm-hmm. Okay. How about your clinic in Manchester, UK? So do they do PRGF?
I'm not sure that I'm not aware of any clinic in the UK doing this PRGF. No, so probably it's easier simply to hop on a flight and come to any of our Spanish clinics because it's sort of straightforward. The regulatory environment in the UK, it's quite strict, so these experimental methods are not readily used.
Mm-hmm. Okay. Sorry, Karen has a follow-up, okay, from our previous question. So, okay, does it depend on the starting point?
You mean when the injection is done, sort of like...
That was the question. What increase in follicles can typically be expected after doing
like whether it's done during ovarian stimulation or whether it's done...
Okay.
You mean, starting point of the follicles. No, like you mean, yeah, understand.
Exactly. Thanks, Karen.
No, probably not. No, I mean, okay, it would be more difficult to notice if somebody has 6, 7 follicles and it increases to 8, 9. If somebody has only 1 or 2 and then suddenly we see 4 or 5, then it would be definitely a significant increase. But probably we would only, even a marginal increase could be helpful. No, so again.
Of course.
And again, an increase in the follicles is one thing. What we need to see whether during the stimulation we have more eggs.
All right. Thanks so much again for the clarification to this question. Definitely something that everyone is wondering and want to know, that's for sure. And if you can have a look at this, what is the difference between endometrial PRGF and regular PRGF?
No, the product is the same, sort of, but the site of the application. No? So endometrial PRGF, I'm just implying that we use it to introduce it in the endometrial cavity with the aim of improving the endometrium, whereas with the ovarian, we inject it into the ovary. No? But the product is very similar.
Okay, brilliant. Thanks so much. Jorge would like to know if he can reach out to you. I can help with that.
Yes,
so it's not a problem.
Of course, to our
not a problem. I will be able to forward this to Dr. Bodri, okay, Jorge, and I'm sure you will be able to help each other as well. Thanks so much indeed. And do you believe, in autologous mitochondrial injection?
I think there are some recent publications that sort of this method, which was also also started in Japan, and it did not gave the results that were expected. No, so probably I don't have experience with this, but according to the literature, it's not something that is a viable thing. Of course, mitochondria are very important in the eggs, no? So that was the whole point of starting this line of research. But I'm not aware of any positive results with this.
Of course, that's understandable. Thank you, indeed. And Derek has one more question. How is this different from embryo glue?
Embryo glue is just like hyaluronan, which is hyaluronic acid, which a medium enriched with hyaluronic acid that is used as an adjuvant to the embryo transfer, where with the idea maybe that embryo can stick better to the lining. But endometrial PRP is different because it is applied like maybe a week or so before the embryo transfer. So these growth factors can have a positive effect on the lining, even enhance implantation with through mechanism maybe that we potentially don't understand, but these products is much more different than just maybe like a simple sort of glue that tries to enhance the sticking of the embryo.
Thanks for explaining. Thanks for your question. And regarding the upcoming event on endometrial PRP, can you tell us where anyone can register?
I think it will be another collaboration with My IVF Answer, so it will be advertised in time. So we are happy, and it will be later available on YouTube.
Stay tuned.
So
exactly.
Yes, it's not a big
Stay tuned, and of course you will see it. I wanted to double check, of course. So please just wait for us. We will definitely post this soon enough on the website as well. Okay. And of course, let me just have a look. We will be finishing. There are a few questions left. So if you can have a look at this one, how long does it take to do PRGF? Can one travel immediately afterwards? Asking to know how many days I will need to spend in Spain.
It's very straightforward. Probably it's even less invasive than an egg collection because the ovaries, are not necessarily stimulated. But even with egg collection, some patients travel on the same day. Although we do recommend them for stay at least like 24 hours, and if everything is fine, then travel on the next day. Probably it's safer to travel on the next day, but it's definitely not a long stay in Spain, maybe 2 or 3 days or so.
Brilliant. Thanks a lot. And possibly our final question for today. So if you have anything else, go ahead, type those in. Is it possible to get PRP in Spain when 51?
We would evaluate, so I would recommend you to contact our clinic. We would evaluate each case, what kind of PRP, is it anything like potential ovarian stimulation or any simpler treatment. We would evaluate it and get back to you. So each case is evaluated individually.
Understood perfectly. Thank you so much indeed. And I believe, as I mentioned, it looks like this has been our final question. So everyone, thanks so much for your time, for asking all those questions. Thanks, Dr. Bodri, for your brilliant presentation. As you can see, there are comments coming up here. So everyone definitely found this useful, I'm sure. Thank you indeed. Before we let you go, anything else you would like to add?
Thank you. Yeah, so definitely it's an interesting topic. As mentioned, many clinics are trying to develop this method, especially in Spain. Our clinics has started it a couple of years ago. So especially with endometrial, that I hope to present through my IVF soon. We do already have some consistent results that I would like to present you. And if it works in endometrium, then probably it should also work in other sites, as it has been shown in other fields of medicine.
Brilliant. Thank you so much indeed. It's definitely a topic that I'm sure will come back here. And I'm looking forward to the webinar on endometrial PRP as well. This definitely is interesting. And thanks so much for bringing this to us, Dr. Bodri. It's great to have you back. I just want to encourage anyone to just simply register for our next webinar next week at 7 p.m. on Tuesday. We will talk about who will be back and will introduce this topic. So if this is something that might be useful for you, sign up right now and save your spot, of course. And again, I would like to say thanks to Phenomatch as they are supporting our European Fertility Society. And this is it for tonight. But as you know, we will be back. Dr. Bodri, as always, I'm looking forward for some more events coming up. I know that it's going to be interesting, no doubt here. Everyone, stay tuned. We will be back. There are more and more events coming up. Thanks so much again, and hope you will be able to join your evenings as well. Thanks so much.
Thank you very much. Bye-bye. Thank you.
Thank you. Bye.